nursing documentation is probably one of the bedrocks of looking at any patient. When we review data of any patient, I think so nursing documentation has been the bedrock of it. Being a doctor, I can just when I don't have any hesitation in sharing that sometimes the doctor documentations, medical documentation is not as appropriate as nursing documentation is there. So while we discuss this, I think so today we have a stellar panel of 4 senior members from the healthcare sector. So it will be interesting to see, and we'll interact and we'll hear their opinion on what all to do going forward and on the nursing documentation as we look at it, the rational essential documentation for effective patient care. So what I'd like to say is that what is the basic purpose of documentation? The primary purpose is obviously to facilitate information flow that supports continuity, quality, and safety of the patient. And with it attendant things are always there, like accreditation, accountability, legal requirements, the financial part. But overall, the most fundamental thing is patient care. How do we plan for care? How do we hand over? How do we ensure that if you look at as time has progressed in the healthcare sector, nursing has been burdened with a lot of documentation, lot of paperwork. So I think so this it will be a good thing to sort of brainstorm on what to do and how do we reduce their paperwork and not slow the productivity. Dr. Suneel, I'd like to just ask you a few things. One is that sometimes, a lot of times, we see this documentation from the legal perspective. I think so. A lot of us we start becoming because of litigant society outside. I think so. We should not be looking at from the legal point of view, but as far as what is the best in patient care that is that needs to be documented. So, the way things have evolved, everyone looks at that in a big way, and that and the documentation as far as accountability is concerned. How do we look at these two parts and sort of factor that in so that we give guidance to our nursing colleagues across the healthcare sector? Over to you, sir.
Yeah. So I take this opportunity to thank Kaho. I am supposed to talk on an administrative topic towards nursing from a clinician's mouth. So a definitely challenging task. And I'm also asked to talk on cost and legal implications. Yeah. Now, as for the legal implications as concerned, anything and everything can be mandatory. Anything and everything can be mandatory. So you can decide what needs to be done, what has to be done, and what mandatorily has to be documented. Now, as far as the cost is concerned, I was thinking a bit more on the cost for the simple reason that why we think any article or anything as costly. Some things we say price, some things we say cost. Some items we say costly. But the simple reason that when it adds value to your processes, it will be price. It will not be called cost or costly. I draw all of you to this clinical audit, nursing audit done in one of the hospitals where they have analyzed the ward arrests, cardiac arrests versus Muse score. Very, very fantastic audit. And they found that only 2% of the cases, Muse score alerted the RRT. Remaining 98% of the cases, it did not alert. For the simple reason that all the nursing staff were charting the Muse audit, but there is no alert placed. The reason may be totally different. So I was looking into these cost and medical, the nursing documentation, what's happening. I was interested to read this article by Madam Judith et al., the Beneficiary Act in the Journal of Nursing Administration. They had analyzed the cost versus the nursing activities. They divided into patient care activities versus non-value adding, which is coordination of the care and documentation, versus the 4 patient care activities like assessment, teaching, treatment, and psychosocial support that is given to the patients. And it's a huge surprise for the study, from this study, that 44% of the cost is for patient care activities, and 55 or 56% of the cost was for non-value adding activities. That's what they said. That is coordination of the care and documentation, which that means to say, if I'm spending 50,000 rupees for a nursing staff, 28,000 is wasted in non-value adding services, which any person other than a qualified nurse can do. Even I repeat it, 55% of the cost is wasted in non-value adding. That means to say, a registered nurse need not do this activity. Anybody with a graduation degree can do this. They also analyze the time, because time is also directly related to the money. 36% of the time, that is 1/3 of their time, is wasted in non-value adding activities, which includes documentation. And most of you agree with me, but most of you may be resisting it to change. The most expensive process was where the A, D, and T, that is admission, discharge, and transfer, and the discharge process. This takes care of the most of the time as well as money. So a few words about how can we reduce the cost of nursing. One, as Dr. Sanjeev said, adoption of computer system. The paper records resulted in wasted time due to duplicate documentation, tracking down records and reports, and poor handwriting, which we can overcome by the computer system or the e-copies or soft copies. However, there are a lot of disadvantage, like computer screen wait time, limited access to the computer terminals, computer shutdowns, unmatched clinical computer systems and programs, and lack of nursing documentation templates and care plans, which may result in more waste of time and more money involved, more cost involved. Second thing is a very, very sensitive issue, the streamlining of documentation. The traditional teaching of subjective, objective, assessment, plan, intervention, and evaluation has been cut now to PIE, problem, intervention, and evaluation. Directly going to the problem, intervention, and evaluation. So it cuts short a lot of documentation and lots of cost in that. And that has moved now to charting by exception. That is, you document only the anticipated clinical path, and you don't document it, stop documenting the anticipated clinical path, and document only the exception and deviation to the anticipated care path. You know that post-operative patient will have pain. So if it is pain more than the anticipated one, there you document and then interfere. So that is a new thing that's coming up, streamlining the documentation and reducing the documentation time and involving the nurses into the patient care on the bedside.
Thank you, Dr. Suneel.